Hello, everybody. We are the Saliva Diagnostics team. We work on development of saliva-based kit for diagnosis and monitoring of systemic diseases. I am Akhil, so I will be the presenter, and our team includes Janisa, Savitri, Shushmita. So we focus on two diseases which are correlated, like one overlapping the other, and which is well established as correlated to one other. So one is the chronic kidney disease and the other is cardiovascular disease. So we took it as a, a brainstorming session and then we thought of narrowing it down. So we came and we narrowed it down to two diseases, that is chronic kidney disease and cardiovascular disease. So let's start talking about the chronic kidney disease. So this disease is basically defined as abnormality of a kidney structure or function, and if it is present for more than 3 months with specific implications on health. And it also has a classical symptom where the glomerular filtration rate is less than 60 ml per minute, and also the abnormality of one or more biomarkers for kidney dysfunction will be seen. So we then came across CKD markers. Like we uh, thought of having a broad approach so that we can narrow it down to what markers we can take and carry forward for our next observation. So we started with going through CKD markers. Most importantly, it is connective tissue anomalies, that is abnormality with connective tissues, and then structural abnormalities, and then increase in albumin content would be seen, and then tubular disorders and increase in sodium potassium content, that is the major electrolytes, those anomalies can be seen, and it can be used as a marker for identification. Also, urine sediments and increase in urea content and increase in creatinine content will also be observed. And if we see both diseases together, then it can be associated with four most important changes. Like these changes can be as a shown as a classical symptom, and it can be figured out that both the diseases are correlated. Most important of which is the myocardial changes, which includes hypertrophy and dysfunction of myocardium. And secondly, it will be the vascular changes, which is associated with increased vascular stiffness and decrease in smooth muscle density. And these two can be also associated with chronic neurohormonal changes, where hormonal imbalance will be observed. And this is mostly seen in cardiovascular diseases and also in chronic kidney disease for a certain extent. And these biomarkers, like including an increase in creatinine, urine albumin, and then catalytic ion concentrations will also be significantly elevated in case of these two systemic diseases. And how the correlation is more pronounced, like this can be observed by seeing its risk factors, which can be broadly grouped into two. So one is a classical risk factor group and the other one is a non-classical risk factor group. So the classical risk factors include most important things like hypertension, dyslipidemia, and obesity, which are commonly observed in many systemic diseases, which is also relevant in these two diseases as well. And since the progression of the disease is extremely slow, proliferation and expansion of these cysts will take time. And as a result of this, an increase in renal vascular compression will be observed because of this prolonged disease and pathological condition, which will activate the renin-angiotensin aldosterone mechanism. So since this is a systemic activation, cardiovascular diseases will be triggered by vascular damage. So once vascular damage occurs, then the sympathetic nervous system will be activated. And then As a result of this, a cascade of events will take place, which includes sodium retention and renal fibrosis. So this renal fibrosis will in turn increase hypertension, and the renal disease will be aggravated. So this is how the correlation between these two diseases are seen. So then we looked at the global prevalence of both the disease, like over the past 2 to 3 decades. And if we see chronic kidney disease, then its incidence and prevalence, like we observed an increase in more than 85% when compared like from 1990 to 2017. And the death due to this disease has been like more than 98%, owing to like 1.2 million people suffering from this disease have died. And then if we see the burden, like 63% of burden in low to middle income countries. So most of the developed and underdeveloped countries are, underdeveloped and low developed countries are suffering from this systemic disease. And the drivers for this disease include population growth, aging, and diabetes. And if we see the global prevalence, as we have seen in the previous slide, the countries with more population, like including India and China, like have suffered from this disease, followed by United States. And if we see the update of like 2022, like it is clearly seen that approximately 1 in 10 people are suffering from this illness. And if we see the estimate over the last 3 decades, there is an increase in death rate by 40 point, like more than 40%. And it is predicted that the disease will be like a major cause of death in the year 2040, and will be like fifth leading cause of death. And the large burden, as we have already mentioned, like it is in low and middle income countries. So what could be the underlying cause of this disease? If we see the statistics, like over the past 2 to 3 decades, it is observed that diabetes type 1, type 2, and glomerular nephritis contribute majorly to the advancement of the disease, followed by hypertension. And if we see the correlation between both the diseases, gout, peripheral artery disease, stroke, and ischemic heart disease. So these four diseases majorly contribute to an increase in cardiovascular disease as well as chronic kidney disease. So since we have observed a correlation between these two diseases, we thought of concentrating on one disease at a time and then focus on the next. So we arrived at the problem where we went through the existing disease monitoring strategies of chronic kidney disease. And then we thought of going through the drawbacks of the existing tests and what we could contribute frugally, like what diagnostic tests can be designed so that these drawbacks can be overcome. So let us look at the existing disease monitoring strategies for chronic kidney disease, which includes the routine blood tests, urine tests. The routine blood tests include an estimation, like estimated GFR, that is the glomerular filtration rate, followed by the serum creatinine test. Then they will test the blood urea nitrogen, followed by test for electrolyte imbalance, including sodium potassium levels and the buffer capacity, so that they will check for the homeostatic balance. And then a routine kidney ultrasound and kidney biopsy would be conducted. And if we come across urine tests, the same estimated GFR, creatinine and urea estimation, and also the electrolyte imbalance will be carried out. And they will also check for urine test for albumin, and the albumin creatinine ratio can also be checked. And if we look at the drawbacks of these tests, like invasiveness of blood tests is obviously a problem. And then cost factor. in case of long-term monitoring for chronic diseases is also an issue. And one more thing is there is requirement of trained professionals. So if you would like to overcome the drawbacks, like we thought of the like there is a need for low cost and non-invasive method to diagnose and monitor kidney diseases, like chronic diseases like these. So we thought of developing an easy to use home kit for monitoring the progression of chronic kidney disease and cardiovascular disease. So we came to a frugal solution, and we could ask this question, like, can we develop a low cost device for diagnosis and most importantly monitoring of CKD as well as cardiovascular disease using saliva as a non-invasive specimen instead of blood samples? So we did a brainstorming session and came to a, like we sorted out, we got a list of saliva biomarkers which are involved in systemic diseases, and most important of these biomarkers are mentioned here, some of which are salivary uric acid, alkaline phosphatase, pepsin, digestive enzymes, and then albumin, kallikrein, and salivary creatinine, and also salivary electrolytes including sodium and potassium. So since most of the biomolecules are present in blood and urine, like they are also found in salivary secretion. And hence, saliva mirrors the body's health and well-being. As a result, saliva could be used as an alternative for blood and urine as a sample for diagnosis of systemic disease. So the bottom line, the question is, like, can we develop a low cost sensitive detection technology to discern the diagnostic wealth of the knowledge trapped within the saliva system? Like there is a saliva sample at large, like can we develop a low cost device using saliva as a non-invasive specimen? So that was what we were trying to achieve. So we developed this table starting with saliva sampling methods, and then we checked for the pH viscosity and the flow rate monitor, that is the physical parameters, and what are the risks involved. Like risks include the diurnal and the circadian variations in saliva, which are extremely difficult to calibrate. And then we also checked for the quantifying the salivary biomarkers. And since the salivary biomarker concentration is extremely low, the detection limit is what the major criteria which we will have to look for. And then we also discussed about salivary electrolyte detection, how to detect salivary electrolyte. And the most important risk factor include interfering with other ions, the interference created by other ions, and how to detect the specific ion which we are looking for. That's what is the challenge involved in this case. And finally, we are planning to devise or design and develop a low cost non-invasive device which has a modular design which can be used for detection of this disease. And the most important risk here is isolation of biomolecules or ions from saliva. How do we isolate, like without uh, any impurities, which is little difficult to achieve because the detection limit is extremely low, and also the concentration of these biomolecules and ions in the saliva is extremely low. That is like 100 times less compared to that in blood and urine. So that is the challenge which we are facing here in this case. So what's next? So initially, like we are planning to uh, work on the detection of creatinine in saliva. So we will start with evaluation of we are planning to use copper sulfate for complex formation with creatinine, and then we will be identifying and calibrating this detection limit, which is most important in case of saliva as a sample. And then we will try to validate this experiment using artificial saliva, of course, initially, and then we will try to compare the salivary creatinine levels with creatinine levels of blood and urine. After the comparison, we are planning to develop this paper-based device and testing it on human saliva samples. So we will start working on creatinine initially, and then we will take it forward to the detection of sodium potassium, that is the electrolyte ions in saliva, and also detection of urea in saliva, and then testing for the albumin creatinine ratio. So once we can, like, we achieve these four criteria, then this could be used as a long-term monitoring strategy for um, testing uh, chronic kidney disease as well as cardiovascular disease. So this could be used at home as well. So instead of going to a hospital, a do it yourself home kit could be devised, and it can be used for long-term monitoring of these systemic diseases. Yeah, thank you.